Welcome to Sexual Health and Breast Oncology, a multidisciplinary approach to management. We are so glad you could join us today. My name is Elaine Gonzalez. I'm the Community Education Manager at the Breast Cancer Resource Center, or BCRC. I'm pleased to serve as your moderator today. The Breast Cancer Resource Center, BCRC, is a community-based nonprofit serving Central Texans impacted by breast cancer since 1995. Strengthened by our mission to empower those affected by breast cancer with personalized support and compassion, and in collaboration with our community partners, BCRC envisions a future where no one faces breast cancer alone. BCRC offers individualized patient-centered care for diagnosis through treatment and into survivorship. Through its two pillars of support, guidance, and education, BCRC's certified patient navigators, whom are all breast cancer survivors themselves, empower those touched by breast cancer to become active and knowledgeable participants in their healthcare journey. The Breast Center at Weill Cornell Medicine and the Meyer Cancer Center consist of 3 sites within the academic home and the New York Presbyterian, one of the nation's most comprehensive integrated academic healthcare systems dedicated to providing high-quality, compassionate care and service to patients in the New York City metropolitan area, nationally and around the world. Weill Cornell Medicine is committed to excellence in research, teaching, patient care, and the advancement of the art in medicine through the maintenance of scientific and clinical scholarship. The Meyer Cancer Center's mission is to ensure that patients have access to emerging new therapies in a supportive and caring environment while training future researchers and recruiting leaders in cancer research and clinical care. The breast cancer program team members are committed to reducing the morbidity and mortality of breast cancer in all populations. This program is provided as part of the cooperative agreement awarded by the Centers for Disease Control and Prevention to expand our programs for young women. The purpose is to increase the availability of supportive services for young breast cancer survivors, young women with metastatic breast cancer, and their caregivers and families. I would like to introduce our first speaker. We are so honored to have with us today Dr. Kristen DeVries, Assistant Attending Cancer and Women's Health Rehabilitation Assistant Professor of Rehabilitation Medicine at New York Presbyterian Hospital, Weill Cornell Medicine. Thank you, Dr. DeVries, for joining us today.
Thank you so much for having me. Let me go
I will
ahead and
turn things over to you.
great. Okay. Thank you so much for the introduction. I'm very excited to be here and to be able to present on this very important topic. We are honored to receive funds from the CDC to support the needs of young women with breast cancer and those with metastatic disease. And truly thankful for the collaborative efforts between the oncology department and also including rehabilitation medicine as part of that multidisciplinary approach. So we'll go ahead and get started. And again, the title of our talk today is Sexual Health and Breast Oncology, a Multidisciplinary Approach to Management. I have no disclosures. Just a brief outline of what I will be covering today. We'll talk about some statistics, potential side effects of treatment as it relates to sexual health and the pelvic floor, sexual health, pelvic floor and its link to disability, evaluation of pelvic floor dysfunction, and the management of pelvic floor dysfunction. So as many of us know, the number of cancer survivors continues to grow thanks to new advances in surgery, medicine, and radiation. Between 2016 and 2040, the projected prevalence of cancer survivors will increase from an estimated 15.5 million to 26.1 million survivors across all age groups. In a research letter published in JAMA in 2023, they showed that the number of cancer survivors with self-reported functional limitation has more than doubled during the past 20 years, with relatively less growth in the number of limitation-free survivors. The 70% prevalence of functional limitation among survivors in 2018 is nearly twice that of the general population. And so the authors of this article really proposed a call to action, really urging care teams to better understand and address function, evaluate function as a core outcome, and reimagine survivorship care. And so here we have a list of the top 10 cancers by rates of new cancer cases from 2020. And this is from the data from the CDC. And we can see that the number one is breast cancer, and survivors of breast cancer represent more than 40% of all cancer survivors. So if we hone in a little bit deeper on some of these statistics, we see that approximately 50% of breast cancer survivors report some type of sexual difficulty, and 45% specifically report sexual pain. Sexual health can be affected anytime during or after the course of breast cancer treatment. Half of the pelvic floor dysfunction among breast cancer survivors occurs during the first 5 years of survivorship, and half occurs after that 5 year period, suggesting that there's really a multifactorial etiology to pelvic floor dysfunction and sexual health. Despite these reported frequency of sexual difficulties and pelvic floor dysfunction, adequate sexual health recovery really remains an unmet need. Part of this could be the complexity of sexual health, and other various barriers may include the comfort of the patient and the provider, education, which is really highlights the importance of lectures or experiences like we have today. The World Health Organization defines sexual health as a state of physical, emotional, mental, and social well being in relationship to sexuality. It is not merely the absence of disease or infirmity. So, when we look into sexual health, you can see just how complex it is and how many factors really play a role. It's affected by biological, psychosocial, and sociocultural factors that may promote or inhibit sexual response. Among the components of sexual response cycle are desire, arousal, and orgasm. Sexual desire or libido is influenced in multifaceted ways by physical and psychological health of the patient, past sexual experiences, sex education, relationship concerns, personal beliefs about sex, and many other factors. For breast cancer survivors specifically, it is notable that nipple and areolar sensation can be an essential component of arousal and orgasm. Assessing sexual difficulties includes evaluating the patient's sexual response and pain. Sexual pain can also result from conditions such as genitourinary syndrome of menopause, previously termed vulvovaginal atrophy. It can also be a result of pelvic floor dysfunction or chronic pelvic pain syndrome, just to name a few. Sexual function can be affected by many other coexisting factors, such as treatment for the cancer itself, and then also other medical conditions, including hypertension, depression, antidepressants, and antihypertensives are medications that may diminish libido, arousal, and orgasm. So, again, highlighting how many layers really can play into a patient's overall sexual health. The reasons why women with breast cancer experience pelvic floor dysfunction and decline in sexual health at higher rates may not be at the forefront of providers' minds, because some may think, well, we're not actually directly treating pelvic floor tissues or the pelvis. But we can see here the many ways that breast cancer treatment, can impact a patient and their sexual health. If we're talking about surgery, we think about body image concerns, loss of sensation, lymphedema. When we think about chemotherapy, there's cancer-related fatigue, deconditioning, muscle weakness, immunocompromised state, neuropathies, cognitive side effects, premature menopause, alopecia, anxiety, weight gain, pelvic floor dysfunction. Radiation therapy can lead to painful dermatitis, radiation fibrosis, can also cause early or premature menopause. Endocrine therapy can lead to osteoporosis and fractures, vaginal dryness, weakness of the pelvic floor, and decreased sex drive. And when we think about the mechanism or how patients are affected, We can say that about one third of women diagnosed with breast cancer are premenopausal, and overall 75% of breast cancers are estrogen receptor positive. Chemotherapy in young premenopausal breast cancer patients can lead to abrupt and potentially permanent ovarian insufficiency. Hormone receptor positive breast cancer treatment typically also includes the use of endocrine therapy. And we know that these medications, particularly aromatase inhibitors, block estrogen and estrogen production, leading to a hypoestrogenic state, and can be used for premenopausal patients receiving concomitant ovarian suppression with the gonadotropin releasing hormone agonist Leuprolide or Lupron for premenopausal patients who undergo bilateral salpingo oophorectomies and for postmenopausal patients. Ovarian insufficiency or suppression results in decreased estrogen levels or a menopausal state, leading to this kind of umbrella term of genitourinary syndrome of menopause. And really, this is a broad term and includes physical symptoms such as vulvovaginal symptoms, dyspareunia, and urinary tract symptoms. Essentially, it's vaginal dryness and loss of elasticity, and this condition often results in sexual pain, decreased arousal, loss of desire, and poor sexual satisfaction. Unlike chemotherapy, which is used for a short duration, adjuvant endocrine therapy is administered over an extended period, usually 5 to 10 years. And while postmenopausal women may have worsening vulvovaginal dryness and discomfort with sexual activity, premenopausal women often have more aggressive tumor or cancerous cell types requiring more aggressive local treatment and systemic treatments as well. And these can result in more severe sexual dysfunction and body image related difficulties than in postmenopausal patients undergoing breast cancer treatment. And when we think about these kind of vulvovaginal pelvic floor symptoms, it's easy to kind of get stuck in that detail, but really we need to think about the broader implications as well. And it really does highlight the need for screening a multidisciplinary team to evaluate and treat these various conditions. So when we think about muscle weakness, pain, altered sensation, shortened or fibrotic tissues, hormonal changes, hyperactive muscles, or changes in physical appearance, that leads to functional or activity limitations, including poor postural stabilization, decreased balance, fatigue, pain with sitting, urinary or fecal incontinence, pain with intercourse, and if untreated, can ultimately lead to handicap and disability, workplace limitations, impact on roles as caregivers, institutionalization, burden on family and community, decreased social participation, and decreased intimacy. So, in evaluating a patient suspected of having pelvic floor dysfunction or when approaching our women specific cancers, you can see it's a very complex approach. But when we're really trying to hone in on sexual health, some of the things that we really want to focus on are pelvic history intake. Bladder and bowel function are often impacted by a lot of the changes associated with breast cancer treatment. But if we're thinking about sexual health specifically, and we can see here, we want to really hone in on libido, ability to orgasm, sensation of the breast and genitals, pain, urinary and fecal incontinence, use of lubricants or moisturizers or other topical agents, and hygiene practices. It has been suggested that up to 85% of women with chronic pelvic pain have dysfunction of the musculoskeletal system, including postural changes, as well as changes in the pelvic muscles, such as spasm of the levator ani or obturator internus muscles. If pelvic floor muscle recruitment is delayed as a result of pain or side effects of oncology treatments, then there will be insufficient support during load transfers through the pelvis, which can ultimately lead to SI joint pain, back pain, strain on the pelvic floor, organ prolapse, or incontinence. So, really, we don't have, unfortunately, enough time to really dive into really the full musculoskeletal exam, but really want to highlight that it goes beyond just the pelvic floor and that symptoms of back pain or pelvic pain should be looked at on a broader scale as well. When we're talking about the pelvic floor specifically, it does require comprehensive examination. So if we're looking externally and inspecting, looking at the integrity and mobility of tissues of the perineum, vulva, vaginal vestibule, vaginal walls, as well as the anus, thighs, and lower abdomen. Q-tip tests can be helpful to parse out, is this just purely dryness, or is there a deeper underlying vulvodynia? Is this a new symptom or an older symptom that may have been pre-existing? Tolerance to gentle palpation externally can give you a sense of how a patient will tolerate more of an internal exam. And then also always paying attention to our neurologic exam, including sensation and sacral reflexes. Practitioners who are trained in pelvic floor examinations and feel comfortable doing so can attempt to do a pelvic floor exam as well. And in my practice, I don't use anything like a speculum. It's a single finger, and when you say not using a speculum, many patients breathe a sigh of relief because patients who have pelvic pain find that to be very, very painful, and generally tolerate a single finger much better. But really, when palpating the area, you're looking for tissue integrity, tone and trigger points, laxity and prolapse, muscle symmetry and strength, and ability to perform a correct or incorrect pelvic floor contraction. And there are some contraindications to an internal exam listed here. This is a great depiction of what we're looking for when doing an internal exam. So digital manual assessment of the pelvic floor can identify circumferential squeeze and perineal lift, as well as areas of muscle weakness or asymmetry. Palpation of the pelvic floor muscles are helpful to discern changes in a focal area, including increased tone or trigger points, or is this a more diffuse process and diffusely elevated tone? It allows for more specific areas of treatment and allows you better communication between providers, whether that be physician to therapist or other. But really, we use almost like a clockwork type setup to determine which muscles we're palpating and on which side. It's also important to realize that there are referral patterns. So most patients are not going to say to you, my levator ani hurts, but they may describe bladder pain, buttock pain, rectal pain. And it's important to realize that many of these muscles have referral patterns to other areas. And so we need to use those as clues when approaching our exam. When we're thinking of pelvic floor dysfunction itself, in a somewhat simplistic view, it's good to think of it in three different categories: underactive or non-contracting pelvic floor, which is poor or absent contraction, hypotonicity, and may have obvious prolapse, but it can ultimately lead to storage deficits or incontinence, and support deficits or ultimately prolapse. The next category would be overactive or non-relaxing. And in that category, you see poor, delayed relaxation, hypertonicity, pain, and or resistance with palpation and insertion. And this can ultimately lead to voiding or elimination difficulties and pain. Then some patients have a more mixed pattern. So there's no visible or palpable contraction or relaxation, and the muscle tone may vary, pain may vary as well. These patients may present with a mix of the above symptoms. This slide just further highlights the complexity of the pelvic floor. And if we're thinking about patients who have had prophylactic hysterectomies or oophorectomies, any kind of metastatic disease, or other surgical procedures, you can see how many nerves may be impacted by intrapelvic surgeries, radiation, or other treatments. So I won't go too far into the weeds about this, but really further highlighting the complexity of pelvic floor symptoms. And so as a physiatrist or rehab doctor, we really want to think about the many layers of the goals of rehabilitation for our patients, from restoring continence to improving effective elimination, to decreasing pain, working on neuromuscular reeducation, and really approaching a patient from a comprehensive perspective. For me, one of the most important pieces of treatment is patient education. And it's really, really critical when we're talking about pelvic floor rehabilitation, really educating our patients up front before the side effects come, and not to scare the patients, but to let them know that these are potential side effects and that there are treatment options for them. The earlier that conversation happens, it's easier for the patients then down the line to feel that they can open up about these things versus them feeling, what is happening to my body? Why is this happening? And almost being embarrassed in some ways to bring it up. So, even just planting the seed to let patients know that these are potential side effects, there are treatment options. Feel free to come to me as a provider if you start to notice these symptoms. Really working on motivation to participate and believe in the effectiveness of pelvic floor rehabilitation, to further lead to success for in the treatment of our patients. Now, when we're talking about it more retrospectively, some patients are ready to learn how to cope and talk about a new normal, and some are not. But again, laying that groundwork opens the door for that conversation already. And then further working on education for our providers as well. And this is critical and one of the highlights of why we're doing this today. Pelvic floor physical therapy is a large component of the treatment of sexual health and pelvic floor dysfunction for our patients. I won't go too far into this because our next presenter, Erin, will also be covering this. So this is to highlight the multifaceted approach of pelvic floor physical therapy. And when we're talking about self-care for our patients, really educating on hygiene products and self-care techniques, which are an important part of maintaining vulvar and perineal health. Urinary and fecal control pads are different from feminine hygiene products and offer more absorbency, ranges, and styles. So, talking to patients about options there. Perineal skin products include moisturizers and barrier creams, which can protect the skin from breakdown, especially with our patients who may have poorer mobility. But many of our patients are unaware of these products and may have misconceptions about their use. Educating patients that lubricants are more specifically used for decreasing friction during sexual relations and help reduce pain associated with intravaginal exams, but are not moisturizers and should not be taking the place of moisturizers. And then we'll talk a little bit now about vaginal moisturizers and non hormonal and hormonal options. So, in ACOG's clinical consensus, they really talk about this stepwise approach, and this is often what I employ in my clinic as well. And really, really, number one, thinking about the factors that influence the decision making regarding genitourinary syndrome and menopause treatment, including the severity of symptoms, risk of breast cancer recurrence, response to previous treatments, and personal preferences. And really further highlighting the multidisciplinary approach, and that this really is shared decision making, which centers on these factors and really includes the oncology team, the assessing provider, and also including the therapist and, of course, the patient. The first line treatment really should be non-hormonal methods for urogenital symptoms in individuals with a history of estrogen-dependent breast cancer. Providers should be familiar with different non-hormonal treatment options because trials of multiple options may be needed to find the effective treatment and what works for each of our patients. And so you can see listed here, there are a few options. There are hyaluronic acid-based injections, polyacrylic acid, vitamin E and vitamin D have been effective as well. Lidocaine is listed here. I will talk about that in a moment. That's used more for the treatment of vulvodynia or penetrative pain. So we will return to that. In terms of hormonal approaches, if we have really tried the non-hormonal treatments and failed to adequately address the symptoms, low-dose vaginal estrogen may be used in individuals with a history of breast cancer, including those taking tamoxifen. For individuals taking aromatase inhibitors, low-dose vaginal estrogen can be used. Of course, with both of these cases, it's extremely important to have this conversation with the oncologist and really with the patient to weigh the risk and benefits and understand what the implications may be. This is another summary table of different kinds of non-hormonal options. So again, the vaginal lubricants and being used for penetration, vaginal moisturizers, really being used to kind of coat those cells and may not reverse cellular or pH changes, but can be helpful to maintain tissue integrity and elasticity. Hyaluronic acid gel has been shown to reduce clinical symptoms of vaginal dryness as a safe and effective non-hormonal option. And then vibrators and dilators can be used when we need to stretch the vaginal tissues. This becomes a little bit more relevant when patients have a history of radiation, but patients who come in who have later stage vaginal stenosis or atrophy can benefit from this as well. And when we talk about pelvic pain specifically, this could be a whole presentation unto itself. But really, when we're thinking about vulvodynia or penetrative pain, lidocaine can be an option. I do often caution patients that it can lead to some burning, but many patients do tolerate it well, and it can apply to the vaginal introitus up to 15 minutes prior to penetration. And this can reduce some of that pain. I'll often also use compounded creams, including amitriptyline, baclofen, gabapentin, or some combination thereof, depending on any contraindications, which can be helpful. And that's less of an as needed medication and used more on a regular basis. Intravaginal or rectal suppositories can be very helpful for managing pelvic hypertonicity and very effective, as hypertonicity can often lead to symptoms of vulvodynia. And when we're thinking about more centralized or chronic pains, you can always consider using neuropathic agents, gabapentinoids, SNRIs, or TCAs. Interventional pain management can include trigger points, which is addressing myofascial pain. This is just with lidocaine and the action of triggering. Botulinum toxin has been shown to be effective for high tone pelvic floor and pain. And then considering nerve blocks, including pudendal nerve blocks or others when appropriate. And some alternative measures that I've found successful in my practice include acupuncture, medical massage, and osteopathic manipulative treatments as well. So I thank you for your attention, and I will hand it over to Erin.
Thank you, Dr. DeVries, for that very informative presentation. Um, Dr. DeVries will be back with us at the end of the program for our Q&A session. So make sure to drop your questions in the Q&A box. And now I would like to introduce you to our next speaker. We are so honored to have with us today Dr. Erin Dean, Doctor of Physical Therapy and Certified Sexuality Counselor at Cancer Rehab and Integrative Medicine. Thank you, Dr. Dean, for joining us today.
Yes.
And I will turn things over to you.
All right, perfect. Yeah, I appreciate y'all inviting me to be a part of this panel. It's amazing I wish Dr. DeVries and I were in the same state so I could send people to her that were not getting better with me. Alas. Okay, I'm going to share my screen. All right. Okay, so let me just jump in for time's sake. I work in Austin, Texas. I'm pelvic floor PT and sexuality counselor, just because some people don't know what that means. Basically, a sexuality counselor is someone who has additional training. It's been about 2 years, in addition to, a physical therapy degree or nurse practitioner or any of these other kind of healthcare professionals. Similar to that of a sex therapist. The difference is the sex therapist has the information that I have on sexuality, but they have a mental health therapy background. So I have the information on sexuality with a physical therapy background. So I don't treat people for their past traumas. I basically start from here, basically with cancer, people who've gone through cancer treatment. I start at their beginning of their treatment and address the trauma associated with the cancer, and then moving forwards instead of like talking much about their sexual past as except for as relevant to moving forwards. Anyway, hopefully that makes sense. So some people don't know exactly what we do as pelvic floor PTs. So if a breast cancer patient comes in, we do an initial examination. We'll discuss their bowel, bladder, and sexual habits and problems, kind of screen for any issues. And of course, I address all of those. I'm not going to go into the bowel and bladder problems in this presentation since it's more about sexual function, but that's a big part of what I see. Well, I'll evaluate the entire musculoskeletal system, kind of depending on what their issues are, and how I see them walk in. If I can tell there's something going on right away with the way they're walking, that could possibly be causing their problem. We'll evaluate that. I'll look at the pelvic floor muscles as well as the vulvar tissue. So Dr. DeVries went over a pelvic exam. I do those. I use a finger as well. They're usually very appreciative of that. I'll go into a little more detail on exactly how I do that in the next slide. And then if they're interested in sexuality counseling, which a lot of people who've undergone breast cancer treatment, if I mention that, we can kind of go into that. Their libido has gone down. They've lost a sense of feeling alive or vibrant, and maybe their body's changed and they're grieving that. So a lot of them relish being able to talk about this. So I give them just an idea of what we can talk about, and then we can later, another session, we'll do a full sexual history, and then those will be talk sessions kind of interspersed with the pelvic floor PT, which is usually more exercise, stretching, and manual work. So then we make a plan of care. Like I said, we might do some stretching, we might do some strengthening, depending on what I see is problematic. Nerve glides for different areas that are maybe causing nerve pain. Manual work on bones or muscles, and then also manual work vaginally or rectally, depending. And like I said, talk sessions to dive deeper into the sexual issues. So for intimacy, cancer treatment's main effects that I see are painful penetration, sexual desire changes, body image changes, and relationship changes. So we're going to delve into all those. Pelvic floor treatment for painful penetration. Dr. DeVries talked a lot about differences between lubricants and moisturizers, and also using a vibrator. So a common thing that we will kind of go through is we'll first figure out what they are using, what they've tried. And if they're not using anything, then like she said, we'll start usually with a moisturizer and a lubricant. So the vaginal renewal program, this is, you can look above sexualityresources.com. There's a pamphlet all about this they can kind of go look at, and I hand it to them. But it's basically bringing blood flow to the vulva and vaginal tissues manually. So there's a number of steps involved, including, self-massage externally. So with a lubricant, and I like them to use a hybrid lubricant if they can, because the hybrid nature, there's a hybrid lubricant has both a water-based and a silicone-based component. So the water-based component helps to bring moisture, and then the silicone base helps to seal it in. And like Dr. DeVries was talking about, if they're able to also use like Reverie or a Plens, one of these hyaluronic acid based products additionally, that helps the lubricant then soak in. Okay, so we do Reverie, Replens, and then we get them a hybrid lubricant. My favorite and my patient's favorite is called Oasis Silk. Oasis Silk. Everyone always wants to know that one. There's a few others, but I've had some people react to it poorly, like with an allergic reaction. So Oasis Silk is the go-to for me. And the program involves using the moisturizer. They can do it after their shower in the morning, just kind of putting the, sorry, not moisturizer, lubricant. Use the lubricant all around the vulvar tissues, including on the clitoris and under the hood of the clitoris, because those tissues can kind of start to scar down in some people with menopause, and then that reduces pleasure, reduces sensation. So we put it all around all the vulvar tissues, call it a day, put on your underwear, walk around every day after a shower. And then there's this little funny purple thing over here on this slide. It's called an pelvic wand. It's rigid, but there's the silicone on the outside, and I suggest to them that they get the vibrating one. So we use that internally with that same lubricant, which the Oasis Silk is safe with silicone toys and this object. If you use, just a caveat, if you use just silicone-based lubricants on silicone toys, it can break them down. But Oasis Silk hybrid lubricant is safe with use of this and all other silicone toys. So they use the wand. The funny little end on it can be used for trigger point release, which I'll explain. And then they can use the other side on with vibration and kind of put it internally inside the vaginal and touching the vaginal walls internally. Helps bring blood flow with the vibration, helps to bring that moisture. And for a lot of these people who've lost, first off, they're like, I don't want to touch this. That's a process we go through to get them to want to touch it again. But sometimes they start to do this program, it feels clinical, but it also kind of brings back a sense of pleasure. And for a lot of these people with high tone pelvic floor muscles that are causing pain, if they can have an orgasm, it reduces the tension in the muscles and can allow penetration to be less painful for many people. Some people it does the opposite, but that is for us to figure out together, them and the pelvic floor PT or physiatrist. Okay, so we did the vaginal renewal program, internal vaginal manual techniques. So this one, the breast cancer patients I see, you know, some people come to pelvic floor PT with this chronic pelvic pain that's been there since they tried to put a tampon in the first time. They're not going to be quick. This is not going to be a simple technique for them. But for a lot of these people who just started having pain because their tissues changed, and then all of a sudden they started to guard because sex hurt or penetration hurt, that guarding caused tension in the muscles that Dr. DeVries was talking about, and the lack of relaxation then causes pain. The guarding, especially when there's penetration, of course, because it hurt last time, they're going to guard again and it's going to cause pain again. So sometimes, often actually, that initial exam, I'm teaching them right away a couple techniques and going through some that work for most people to reduce the tone. And then right away, I'm palpating on their pain. They're like, ouch, that hurts. I'm like, try this breath. I'll teach y'all in a second. Or try bulging or try doing a contract and relaxing all the way. And sometimes they notice, oh, it doesn't hurt as much, or it doesn't hurt at all. And that's this aha moment for them because all of a sudden they have some control, right? So oftentimes trauma gets caused because of a lack of control, and we give control back to kind of reawaken that part of the brain that was traumatized. So a lot of what I do has a lot to do with control and pain science and kind of rewiring the brain to feel like this is safe and okay. And then if there are muscles that are tight or weak, we strengthen and stretch those appropriately. This next slide, I'm gonna go over this breath technique. So this is one of the tricks. Doesn't work for everybody. You might notice, some of you will probably be like, this is easy, and some of you will be like, I feel nothing. It's not easy for everybody to do this, but it's also harder sitting. So unfortunately, I mean, I can't see any of you, so feel free to lay on your backs on the floor. If not, just kind of relax as much as you can into your chair so you can relax your stomach. And you're going to put your hands on your low belly, like just above that pubic bone. Close your eyes and just notice your breath. So naturally, when your stomach is relaxed, when you inhale, your belly rises. As you exhale, it falls. Naturally, what's happening in your pelvic floor is when you inhale, the pelvic floor expands down towards your toes. When you exhale, it comes back up a little bit towards your head. So just bring your awareness to the pelvic floor. Inhale, belly big, pelvic floor drops just a little towards your feet. Exhale, belly goes down, pelvic floor goes back to neutral. Inhale, belly big, pelvic floor expands like a balloon. Exhale, goes back to neutral. If that was hard for you, if that was hard for the patient, we would practice it a lot more. They would do it at home. Some of them, though, can do it like this, and all of a sudden their pelvic floor muscles on inhale open up and soften often, and then the pain can go away like that for some people. Then it feels like magic. Obviously, it's not like that for everybody. But that's a good technique. I would practice it on your own before you try to teach it to anybody else, though. So I could say so much more about pelvic floor PT or PT in general, but I have 15 more minutes, and I want to talk to you about sexuality and sexuality counseling, because it's fascinating to me, and it's usually pretty fascinating to my patients. So I can't tell you how many times I've had patients come in and say they feel bad complaining about their sex life because at least they're alive, right? The thing is, sexuality is about so much more than just sex. It's about them feeling wonder and awe, noticing the world around them again. It's about them having vibrance and feeling alive. So it's about their connection to themselves and to their partner or partners and to the world around them. It's a part of getting out of that survival mode that they've been in since cancer treatment started, likely, and towards thriving. So, like Dr. DeVries said, they may not bring up sexual problems in their sessions with you. It's a great idea to ask, to let them know that treatments can affect sexual function. But if you didn't, or if you weren't a part of their pre-treatment discussion, you have to ask about it afterwards. You can just put it on a intake form. Sexual libido issues, painful sex, or any sexual problems at all. Just they check mark yes or no. That's simple. No, great. Yes, address it. There's 1,000 things you have to ask in those exams. I get it. But this, I'll give you, if they say yes, then at least today I'm going to give you a few pearls of wisdom so that you can share them, and also let you know where to go for them to get more help. So sexual desire changes throughout our lives, no matter what, for everybody, any gender, okay? Libido is fragile. It's negatively impacted by stress for many people. Some people are the opposite, but for many people, it's negatively impacted by stress, by sickness, by unwanted pain, and by menopause because of all the things Dr. DeVries mentioned. So feeling desire for sex can be compared to feeling playful and curious. It's less likely if we're exhausted or living in fear. That's why I don't know if any of you have ever had kids, but especially at the beginning, you're exhausted and the desire might be really low, and that's tricky. So that's one often common time when people's desire changes. Another is menopause. Another is aging as we get older, and erectile function changes, naturally. Illness, of course, and of course, cancer, right? It's terrifying. But the thing is, we can spark this desire if we want to. So I'm going to give a bunch of little ways that we might be able to do that. So we'll go over all these. We're going to talk about maintaining intimacy during treatment, grieving the cancer, and then reconnecting with the body image reset, working on the intimate connection with partners, and then other course, which is a term for other things beyond intercourse. Let's see if I can get through this all in 12 minutes. Okay. So maintaining intimacy during treatment, I would suggest you would share with them to try to make time for physical intimacy with their partner. So that doesn't have to be sexual. It can be touching, cuddling. They can even, I have so many patients tell me, I'm afraid if I touch him or even look at him, or that he's gonna come on to me and think it's okay to, or he's gonna want more. So have the discussion, right? Like, I am completely, all the things. I feel all these things. Have zero desire, but I really want to keep that connection with you. Like, when I do this, it doesn't mean this, it means this. Talk about how the partners, all of them, are feeling. So I also, especially when treatment is long-term, the other partner, if there's two partners in a relationship, the non-cancer partners' sexual needs are important as well. And just discussing that, I know a lot of people feel weird about pornography, a lot of people feel weird about masturbation, but opening up some to have those discussions with their partners can be helpful, because if that partner at least even knows that the person with cancer cares about their sexual needs, because it can be really intense. A lot of people their stress reduction comes from orgasm, right? So if this person feels bad for having those desires, there's going to be some resentment possibly that will build up. So being able to have the conversation and kind of think of possible ways to get the partner's needs met while getting the person with cancer's needs met as well, that can actually really help them grow. So this is a big one. Grieving the cancer first before trying to get back into their body or their sexuality. Treatment might make people feel as if things are happening to their body, like they can't control what's happening. They might check out, and they might feel like their body betrayed them. I get that a lot, like they're mad at their body. So those things are all things that also cause traumatic responses in people. We have to grieve them, to feel the feelings around what happened to us, or they have to feel the feelings around what happened to them in order to move through it to the next stage. So again, I'm not a mental health therapist, but I can at least help them with this small piece. And if they can't kind of get through it on their own, then I have them, hopefully they're seeing someone else also. But if not, then I recommend they see like a mental health therapist, right? So how do they maybe grieve their body? We talked about nipple sensation. Breast cancer patients' sensation goes away, especially if they had a bilateral mastectomy. They lost, and not nipple sparing, or even if they tried to spare the nipples but didn't maintain nerve conduction everywhere, then there might be some numbness. And so the patient can actually just lay down. A lot of them don't want to touch themselves. They don't want to touch and I'm talking like months after the surgery, they don't want to touch it. It feels yucky, brings up all these feelings, but they have to feel the feelings, or feeling the feelings will allow them to move through it. So I have them try on their own. Everyone's away, they lay down, they close their eyes, they just feel their own body, and they notice the changes. And it might bring up tears, cry, sob, these things are important. And I've also had patients tell me, I've had this one woman say, I couldn't feel my breasts anymore, which was so sad to her, but she's like, I did that thing and I noticed I could feel my stomach still. And she was planning a deep flap. She'd had expanders, she was planning a deep flap later. She decided not to do the deep flap, rather just get implants, because she realized that she was aroused by the sensation in her abdomen, right? So, they might find that a lack of sensation in one place leads to more awareness and sensation in another place. And then reconnect to their body after this grieving happens. Little ways to do that: noticing pleasure. So I have people put this in their calendars once a day. Notice pleasure, notice pleasure. We move through the day, especially if we're still in a trauma place or a stressful place or a survival place, and we don't necessarily see or feel or hear or smell our environment. So noticing pleasure means me even saying that right now, I can feel the fan on my face, and my face is hot because I'm talking to all of you. And the fan feels really good. But I'm only noticing it because I told myself to notice pleasure, right? It might be the breeze outside or the light coming through and shining on a leaf. Might be the feel of a dog or a cat. It's a common one I hear. So start to regain that association with pleasure. And then the body's response to stimulation likely changed. So let's do a quick, I think this is important enough to do. Let's do a quick exercise called waking up your hands. It's bettymartin.org/hands. You can send patients to go do this on their own if you want, or you can have them do it with you. Just so the idea is it's to learn to access a state of relaxed pleasure. So I want all of you to grab an object, doesn't matter what it is. I'm gonna grab my water bottle, okay? If it's soft, all the better, but doesn't matter. And then close your eyes. Again, we can't see you. And you're gonna, the goal is to notice the pleasure that your hand is experiencing. So you're closing your eyes and you're feeling the object. And you're trying to focus your mind on exactly what you're feeling. So you're noticing the ridges, the softness, the shape of the curves, the smooth parts, the rough parts, and slow your hands down. So take a minute, 1 minute, and just notice what you notice. Remember, none of us can see you. Try to get out of your head about how weird this is. Try to notice the sensation in your fingers and how that feels over all these different parts of the object. And then just take note of how that makes you feel emotionally. So this takes practice. I often do this in the clinic with patients, and then I have them do it at home again because then they're not having me right there. It takes practice, it's mindfulness, so that takes practice alone, being able to focus your mind. But it's the baseline for being able to reignite libido and desire and arousal. Oh my God, I don't think I can get through all these. Okay, body image reset. Just gonna run through it. I say the key is consume media with people with bodies like their own. So try Instagram, Facebook, shows, movies they watch. Try to fill all of that with bodies who are not just the icons of beauty that we say beautiful is in our culture. You know, like get a wide variety of bodies, wide variety of people. I love this book, The Body Is Not an Apology by Sonia Renee Taylor. It's definitely got like a political let's do this together, let's change the world kind of vibe to it, but it's empowering. And that's all I'm gonna say. Sorry. Intimate connection. So the partner may have been in a caregiving role, and so once that's done, they need to purposefully change that dynamic so they can start by doing something together that's novel or new. And with their sex life, start from the beginning. So kind of take out all of the thing, like maybe take note of what they had been doing before and just start from the beginning and grow together. So a study on optimal sexuality called From Closet to Reality, Optimal Sexuality Among the Elderly, Kleinpletz et al. I have this resource at the end if you wanted to look more into it. It's a study on people over 60 in relationships together 25 plus years who report optimal sexuality. So it suggests that optimal sex evolves over time, flourishing when the relationship deepens with maturity and personal growth. So cancer diagnosis and going through that's definitely personal growth and change. Optimal sex is not goal-oriented, but rather focused on pleasure and exploration with humor. So this requires a paradigm shift. So not goal-oriented, meaning arousal doesn't have to happen. Orgasm doesn't have to happen. In fact, when we think they have to happen, they're not going to occur. I mean, I'm sure many of you know this feeling of like pressure. It puts pressure on things and it's no longer fun. So just like taking that off the table as a thing that has to occur can be huge, especially if there's pain. It doesn't have to require penetrative sex, especially at the beginning. What else can they do? So that being said, other course, what else can they do? So what is sex, right? Is it penis and vagina? What about people who don't follow these gender roles? What about people with different anatomy? What about people with difficulties maintaining erections? Or people with changes in their vaginal tissue or other pain in their body? So sex isn't just penetration. So other course is a term describing all other sexual acts beyond that penis and vagina thing. So it's using other body parts or objects to create sensation on the other without penetration. So it's exploring and playing together, again, without goals. Sometimes the best sex has no penetration and no orgasms. Half of you are like, nah, try it. Change the script. So how can it be fun? Play a game. Simon says, do this to me. Don't do it anymore. I didn't say Simon says, right? Start with a different body part. So if you do this one thing every single time, grab the elbow. I don't know. Start with something different. Have kissing only nights where you don't allow yourself to do anything beyond kissing. That can make it so hot. You can make you feel like you're going back to high school or some other time when you weren't doing other things beyond kissing. Maybe you're not taking your clothes off. Tonight we can't take off our clothes, but we're going to have this other quite young feeling of intimacy together. People think that's weird at first, but I mean, I don't know if you enjoyed making out with people at one point in your life and that's all you did. Oh, I got a heart. Yes. It's fun, right? So it can kind of stimulate that feeling of youth and aliveness that probably was exciting at one point in your life. Thanks, guys. Use a toy. People are afraid of toys and think it means that, if I have a vibrator, it means that I don't want my husband's penis, but that doesn't mean that. Especially, the vibrator could be used on the perineum of a man also, or another place. It can be for both of you. It can be used on your spine. It can be, there's all different kinds of toys. They don't necessarily have to mean or be negative, but of course, someone one-on-one with me, we would have a discussion about that before I suggested that they use a toy if they're against it. And then a deck of cards, Best Self, Intimacy After Dark, very fun. There's a lot of parts to it. It's not just like sexual stuff, but there's how to have the discussions about sex. This card deck specifically is amazing. All right, that's all the time I have. Here's some info. Y'all will get these slides, books, and some of the websites that I recommended, and then my info. I'm in Austin. People can see me in person for pelvic floor and sexuality counseling or online at my website. I have a way to get a hold of me without the pelvic floor part. All right, thank you all so much.
Thank you, Dr. Dean. That was a wonderful presentation. I'd like to invite Dr. DeVries and Dr. Stearns to join us on camera. I'd like to introduce you to our Q&A facilitator, Dr. Vered Stearns, a medical oncologist at New York Presbyterian Hospital, Weill Cornell Medicine. We have about 15 minutes for questions. We'll do our best to get to as many as we can. Dr. Stearns, I will turn it over to you.
Thank you so much. First, I'd like to say this has been really a wonderful webinar, and I learned from both of you, Dr. DeVries and Dr. Dean. And I thought maybe we can start having a conversation based on some of the questions that were sent in advance and try to then get to a little bit more specifics. And for those of you who sent questions, we're not really able to provide uh, recommendation for your specific needs if you're a patient, but hopefully we'll be able to give you a suggestion on how to bring this up with your provider and how to get referral. So as you've heard, I'm a medical oncologist. I see a patient with breast cancer, and over the years, I had quite a few very young women with metastatic disease, and fortunately, many of those women are living with or beyond their cancer for years or decades. And as they do, we really need to be able to address their needs. And one of the things that's tough is to bring every possible side effects or concern during a very short visit. So having tools in the clinic that ask the question, or empowering the women to ask a question about their concerns, is important. Do you have some suggestion for our audience today? How can they encourage the women to bring up the topic?
I'm happy to jump in. All right.
Please.
Is that a little clearer there?
Yes.
So I think, thank you for asking that question. I mean, I think really when you see a patient from the beginning, really opening that door from the beginning, once a patient is really into their treatment journey, obviously a lot of other things come up, and maybe it's not at their forefront of a patient's mind, but I think setting the stage early for patients really encourages them to kind of be aware and say, hey, this person cares about that symptom, so maybe I should bring that up. I think as providers, we often focus on, tell me about your fatigue and your diet and symptoms of neuropathy, and let's look at your labs. And we focus on the medical aspects. But I think when patients realize, hey, my provider is really asking about me as a whole, then they tend to open up a little bit more about them as a whole and what is really impacting them. I think screening tools, as I know we're also working on developing some of those in our practice, and trying to figure out the best way to capture these really functional limitations throughout. There are some validated questionnaires that you can look up online, and they have a variety of different questions, so you can also always tailor those as well to whatever your practice looks like. But I think the earlier the better, and then the more providers that are educated on asking these questions, the better.
And it can be simply saying any issues with your sexual function or your sexual health, and if they feel kind of weird about that at first, I mean, I'm sure the whole journey is strange, so they can decide to say no in that moment, like no, but they might come back later and be like, actually, yeah. Simple.
I think in my experience, relatively few or a small percent brings it up on their own. But when you ask the question, there's usually quite an interest in learning more and having referrals. So, so if we meet with a woman who has expressed concerns, how do you recommend that the referrals will take place? I know that I like to make sure that a woman had a gynecologist and had some sort of an exam before we referred her to either pelvic floor therapy or to additional sexual consultations and so on. What would your approach be, and how would we as healthcare providers can assist the patients who are struggling?
Can I answer that? Yeah. So you don't actually, I've actually had providers say, well, I need them to go see a gynecologist before they send them to me, but you don't actually have to. We're trained as doctors of physical therapy now so that people can send, like we're direct access in most states, so you can send the patient directly to us and I do the exam. If something is beyond my scope, then I can recommend that they see this person or that person, but they don't necessarily have to see a gynecologist before seeing me.
I second that. I will often get patients who come to me who have already started physical therapy. So I'm not a gatekeeper from a rehab perspective in any way. Oftentimes I'll have a pelvic floor physical therapist refer to me and say, hey, we're really stuck here and we need to add additional interventions. How can we collaborate and work together? But really any provider, it's just like making a physical therapy prescription for back pain. Any provider can prescribe it. I think that's where the education piece is really important too, though, of, when you bring up pelvic floor physical therapy, and I think somebody wrote occupational therapists can do it too, and you're correct, that can be done too. So when we're talking about pelvic floor therapy, patients are often scared and say, well, what does that mean? I don't want my husband touching down there or my partner touching down there. So why would I want some stranger touching down there? So I think that's part of the education piece too, and that it's not necessarily a scary thing. It's really another tool and another provider to support them through. And as Dr. Jean was saying throughout, it's different ways to approach the problem. And if a patient feels uncomfortable in one way, it's finding another way to address it. And kind of laying that groundwork of reassurance will most likely make the patients more compliant in the recommendations.
Great, thank you. We got many questions about specific products and estrogens. So maybe we can talk a little bit about that. And again, I'm happy to provide my medical oncology perspective as well. Lots of questions about vaginal estrogen, and then also about Reverie and Ristella. So can we talk a little bit about how do you approach the interventions, in particular the vaginal compounds and other interventions that may help help the vaginal rehabilitation, and how is this done in conjunction with pelvic floor therapy and sexual counseling?
Do you want me to start, Dr. Dean, or do you want to?
You go.
Yeah. Okay. So in my presentation, I did go through kind of my stepwise approach. It's first having that conversation and educating the patients on what the difference of products are and what we're hoping to address with each product. Being that I'm a rehab physician, I will never start a patient on hormonal supplementation or therapies without consulting with the oncologist first. And generally, to be honest, it's the oncologist that will kind of take ownership of that. Again, especially in our estrogen positive breast cancer population. In terms of products, I think it's very patient variable. Some patients are more sensitive to certain products or have allergies to certain bases. Some products are more plunger, so it's like a liquid and you use a plunger to put it in versus being a suppository. And so we'll talk about what those look like, and what sometimes there'll be trial and error and say, oh, I've tried this product for 3 months and haven't noticed a difference. And we'll say, okay, let's switch to something else. Patients who have significant vaginal atrophy or stenosis or vulvodynia tend to not love the plungers because it can be somewhat aggravating and traumatic trying to get it in. So we'll tend to try more of the bullet, compounded suppositories that they can just insert digitally with a finger, and they tend to tolerate that a little bit better. It goes into medication options as well, and trying to manage tone. Some patients are not able to get suppositories in because their pelvic floor is too tight, and that's a whole nother conversation. So I don't necessarily want to endorse or say one product versus another. I think it's very individualized based on the patient and their preference and what they're comfortable with. And then really emphasizing that if if patients really are refractory to non-hormonal options, that it's really a multidisciplinary conversation, and the oncologist really should be looped in when talking about estradiol supplementation. The other piece to this is a lot of times estradiol is used as a vaginal insert. And what I've actually found very helpful is if it's in a topical cream form, is having patients apply a little bit along the vaginal introitus on top of inserting the estradiol internally. So it gets direct absorption into that vaginal entry and can add another layer. And some patients have done that instead of the full insertion of the suppository because they feel a little more comfortable with using less versus more if they have decided to use it. So that is another option as well.
Dr. Dean, do you want to add?
I usually add in, put it around the clitoris as well, just for the reasons I discussed about adhesion. But yeah, I love that. Put a little bit on the introitus because that's what we want really is for it to come slowly out over time. Also, people tend it can come out and people hate that. It gets all disgusting in their underwear. So I suggest that they do it in bed before they go to sleep. That way it kind of absorbs and doesn't all come out. Because then I've had people be non-compliant because of that gross factor, you know.
From an oncology perspective, we've been following the American College of Gynecologists recommendation. We do know that patients on hormonal therapy, especially a aromatase inhibitor that's associated with quite a bit of vaginal dryness, who do receive some of the vaginal estrogen preparation, there could be initially some absorption where the vaginal wall is very, very thin and dry, but as it gets healthier, the absorption is very, very minimal. So it needs to be a shared decision making that's based on quality of life considerations for women. So, and we try to start with the non-hormonal interventions and but support the use if needed. And we try to recommend the low dose estrogens. It's usually Vagifem and Estring. There may be some others. There have been a couple of questions about Reverie and Ristella. Do either of you have experience with those?
I don't know Ristella actually.
Yeah, I'm actually not familiar with Ristella either. I actually had looked it up when I saw it in the chat. I have a lot of patients who like Reverie. That's the bullet form, so it's a little easier to insert. But I don't have as much experience with Ristella, but I have had good success with Reverie.
Then the other compound that we were asked about was testosterone. Again, from my perspective, testosterone can be or does convert to estrogen. So it's not something I use commonly, but in women that have vaginal dryness and also concerns about libido, we've occasionally used that. But again, I usually work with a gynecologist or a sexual counselor or someone else before making this recommendation for patients.
To piggyback on that, I have seen some patients who have been prescribed topical estrogen and testosterone, which they'll use along the vaginal entrance as well. I don't have as much experience with that, but that's generally once estrogen has been tried and failed prior to adding in another hormonal agent. I'll also say that some patients, if they have patients who have underlying vulvodynia and a hypersensitivity there before the onset of vaginal atrophy, can be very sensitive to certain types of bases. So if the estradiol cream itself or the suppository or whatever you're using is causing burning, you can have specialty compounding pharmacies make the estrogen cream or suppositories in a more hypoallergenic base. So that's something to consider as well.
Very helpful. Oh, we're out of time. So the only other thing I would again say is talk to your doctors, talk to the patients you're advising, make sure they bring up their concerns in a conversation. And again, many of the questions that have been more specific, those are shared decision making recommendations that your oncologist or other provider can help you with and guide you. And if you're not getting the right answer from your provider, do seek out to some of those resources that have been shared with you today. And with that, I'm going to give the mic back to Elaine. Thank you so much for the opportunity.
Thank you, Dr. Stearns, and thank you, Dr. DeVries and Dr. Dean for being with us today, sharing your expertise. Wonderful presentations, and I love the discussion. Thank you so much. I want to say thank you again for joining us, and have a great day.